Good evening to all. Once again, at the outset, I want to thank Patta sir for giving this opportunity and platform, and welcome all of you for this today's case capsule discussion. And today, for today's discussion, I have selected a case of hepatolithiasis. As you all know, that hepatolithiasis is not only a complex disease but also a very curious disease. It is complex because the treatment is very complex. It needs a team approach. It needs a very customized way of treatment, and every case has to be dealt with depending upon the morphology. And it is curious because the various aspects of hepatolithiasis are unexplainable, right from the pathogenesis to the epidemiology. And when I say epidemiology, this disease is exclusively a disease of the East Asian countries, which includes China, Korea, Japan, Vietnam, Thailand, Philippines. These are all the countries where this disease is exclusively reported. And the prevalence of hepatolithiasis in these countries is extremely high, to the tune of 30 to 40%. And this is a completely different entity from the regular gallstone disease that we see in day-to-day practice. Apparently, there is a demographic divide between the East and the West. The Western countries, these cases are very rare. Even in India, it is very rare. And that's the precise reason I brought this case capsule for discussion, because in a lifetime, we will see only few cases of hepatolithiasis. And I want the opinion and inputs from all the panelists as well as from the audience to share their experience of how they manage these cases. Because the planning of treatment of these patients can be very important in the outcome. Now, the largest experience of hepatolithiasis has come from China, because they have the vast experience of managing these patients. And as far as the Indian data is concerned, I think the largest experience has come from CMC Vellore, where they have designed their own way of tackling these stones with the help of the urology instruments and laser lithotripsy. Now, with these few, with this introduction, I'll be going to the case proper. This is a story of a 35-year-old male who comes from northeastern part of India, and his main symptoms is he's having recurrent abdominal pain, epigastric, fever, and jaundice. All these things are only mild symptoms, but he's having these symptoms for the past 6 months. And he has been going to different hospitals and getting investigated. And finally, he comes to Chennai. And when I say a Northeast patient comes to Chennai, I think I don't need to mention which hospital you will land in. This patient on the clinical profile looks, he's having a mild icterus, but his vitals are stable. There is no evidence of cholangitis at the moment. He's stable. There is no fever at the present. The LFT shows a mild derangement in the form of bilirubin of 3.5, raised alkaline phosphatase, AST, ALT are marginally raised with a normal INR. He actually has a couple of ultrasound reports done outside, which was not very conclusive. It just says that CBD is dilated, extrahepatic and intrahepatic biliary radicals are dilated. That kind of information only is provided by the ultrasound. And this patient comes to the hospital, and there, for some reason, they go for a CT scan. Normally, when we have a biliary pathology, especially a suspicion of a stone, we go for an MRCP. But here, they go for a CT scan, which means that obviously the quality of CT is extremely high, and probably a dedicated GI radiologist is providing a lot of information that the surgeon or the gastroenterologist wants. So as I take you through the various images, you can appreciate the high quality images, and these are all multi-slice images with multi-planar reconstruction and giving a lot of information for the clinician. That's very important. So this section shows IH bar is dilated on both the lobes of the liver, but the left duct is extremely dilated. It's grossly dilated. The right side also mildly dilated. And in this section, it talks about the right hepatic duct seems to be, it's shown, it's mildly dilated. The confluence seems to be patent, and they have shown the proximal part of the common hepatic duct that's slightly dilated. And you can see the left duct is massively dilated, with completely packed with stones. And these stones are always calcium bilirubinate stones, which means that it will appear dense on CT scan. And the radiologists have also pointed that there is a stricture in the left hepatic duct. And this information is of great importance to the clinician in decision-making process, presence of a stricture in the left duct. Now, this is another cut showing the presence of stones, and they have shown the head of the pancreas. Sorry, unfortunately, the reconstructed images are so good that I am omitting all the axial images. And this photograph is really one for an archiving, because they have demonstrated a large roundworm, the Ascaris lumbricoides, in one of the loop of ileum. Whether it's always a controversy whether hepatolithiasis is caused by biliary helminths, though it has not been proved, but definitely biliary helminths has been shown as one of the theory behind hepatolithiasis. And in this particular patient, to see a large roundworm in the intestine is something very interesting. And that's another section showing the dilated bile duct, and the distal end of the bile duct, we do not know whether there is a short segment stricture or some sludge sitting there, because the bile duct seems to be slightly dilated. And they have mentioned that pancreatic duct opens separately into the duodenum, and there is no formation of ampulla. So much of information provided by the CT scan. And before I open this case for discussion by the panelists, I want Dr. Patta's opinion for the quality of the CT images.
Before Patta, can I interfere?
No, you can't interfere.
No, that is exclusively for
Yeah. See, the very reason, Shankar, you said that this person from Northeast has gone to a particular hospital, one of the reasons is this. The quality of the CT. Well, now you can say that, whatever you want to say.
No, this CT is classical of Dr. Ruchita's CT. So this is, you can say, show to any gastroenterologist in Chennai, they must be aware of this reconstruction and images. As you strongly said, that's the reason most of the gastroenterologists in Apollo Chennai prefer a CT rather than a MRCP. That's the reason I think we don't learn MRCP over the years, because of these good quality CT images.
Now, this CT, what is the oral contrast that is given? Generally, a roundworm also will eat the whatever contrast. In bariums, it does seem to eat, but here I think the roundworms don't fashion eating whatever contrast is given.
Ruchita usually give only water, oral water only. She don't use
think,
it's only a negative contrast that they give for a CT scan.
Yeah, okay.
Anything,
you wanted my opinion specifically for any reason. I've been very accustomed to these images for a long time, but unfortunately I miss them now.
No, I thought you are the beneficiary of the good quality CT scan for a significant part of your.
I'm the beneficiary of good quality radiologist.
Yeah, that's good.
And a gastroenterologist, of course.
Gopal, that's for you. Yeah. Okay.
Both I miss.
Okay. What next for this patient? You had the CT images. Now we'll come to the panelist discussion.
Surgeons first.
Surgeon first, yeah, that's correct. Because this is a surgical disease.
Prathapan, we'll start with you.
Looking at the image, I think this patient will benefit by left lateral segmentectomy only. Because I have experience of more than 100 cases. I never published. I am on the process of publishing. I have done more than 60 left lateral segmentectomy for recurrent pyogenic cholangitis. What we call here, it's a very common problem.
Okay.
It's a very common problem in the coastal areas of Malappuram and Calicut.
Okay.
So even now I have a patient, after 4 CBD exploration, he has come with a cast forming calculi in the left bile duct.
Okay.
So I have done many surgeries, but the surgery which gave maximum benefit is by doing the resection of affected segment rather than just taking out the stones.
Prathapan, what do you think the incidence of hepatolithiasis is very high in Malappuram district? Have you done any?
I don't know. As you already told, there is some correlation with the worm infestations, their hygienic part, etc. They are all belonging to the coastal areas where there is overcrowding, increased incidence of ascaris. I have seen one patient in which CBD exploration done first that actually drained out ascaris worms.
Okay.
After few months, she developed again pain. But we thought the patient is having worms, but we could remove only stones, no worms.
Okay.
So I think there is a good correlation between ascariasis in our part.
And this pattern is it very peculiar to your area or the rest of the Kerala also?
It's very peculiar to this area only, because I have discussed with many gastrosurgeons across Kerala.
Okay.
Only Dr. Ramesh has seen, but most of his patients belong to this area only.
Then you have to publish, because this is 60 to 100 cases seems to be a big number. Yeah.
Sure.
Yeah. Dr. Bhaskaran, sir.
Shankar,
Yes, sir.
MS Kuru and others from Shere Kashmir had extensive experience with ascariasis in the biliary tree.
Yeah.
But they never had the problem of hepatolithiasis.
Yeah.
The cholangitis was caused more often by the worm or obstruction, and it settled down once they did whatever was required. I wanted to check, so I don't think that is directly the cause for hepatolithiasis. I wanted to know whether there is any pancreatic head mass, inflammatory mass or something, where we can consider the possibility of autoimmune pancreatitis plus something else high up, other than recurrent pyogenic cholangitis. Overall, it appears to be RPC, but then we should also consider the possibilities of other things which we see in India. So
Okay.
maybe we can look for primary sclerosing cholangitis. Maybe we can do the markers for them. Whether they are very useful in diagnosing, I can't really say.
Yes, sir. As you correctly said, the hepatolithiasis in India as well as in the Western countries is because of not because of the what that is seen in the East Asia, but it's because of say colorectal cyst or some other worm infestations. So the pattern of the etiology was different from the East Asian countries.
Shankar sir.
Yes, Elango. Yeah.
Sir, you had the stricture. It was a localized disease.
Yes.
And the left lobe is packed with stones.
Yes.
But normally, when we evaluate for intrahepatic stones, we'll see whether it is bilobar or unilobar.
Yes.
And then associated strictures, the lobar atrophies. And then we should also look for portal hypertension, isn't it?
Yes. Yes.
We should also look for cirrhosis and portal hypertension. Did
Correct.
you have? Is there anything on the platelet count? Do you have that, or
no?
Does the imaging suggest portal hypertension?
No, this patient was not having any evidence of portal hypertension, both on endoscopy as well as on blood investigations. Yeah.
No,
Okay.
this patient. Can I?
Yeah.
This patient. This patient has got a specifically localized disease. I think
Okay.
it's not a generalized problem affecting the hilum or lower CBD or the hepatic duct. So the chances of secondary biliary cirrhosis or something related to this disease is very rare. Can be a separate entity.
No, that will happen if there is a bilobar disease.
Yeah.
Suppose you have hepatolithiasis on both the lobes, then you can go for secondary biliary cirrhosis.
Yeah.
So
Now, how to explain the dilated bile duct and the common hepatic duct? Because the stones are obviously seen in the packing the left hepatic duct. Is it also associated with some concretions or sludge?
Some cases can be associated with choledochal cyst as well.
Okay.
Some of the cases.
Okay. So, Prathapan, you said you'll go for a left lateral sectorectomy, but are you not worried about the so-called stricture in the left hepatic duct? A left hepatectomy will be a better option, no? So that you will take care of the stricture also.
If you can complete, here the issue is the bile duct alone, not the issue of parenchyma or other. If you can access that ductal area and you can clear all the stones through that opening, actually it is a retrograde clearance of bile duct rather than the usual biliary exploration. We will open that area and remove all these stones which are connected to that particular segment.
So basically, your option is to go for a left lateral sectorectomy or a left hepatectomy. And you want to clear those complete stones as well as the stricture.
Yeah, if you can access the junction between the segment 4 ducts and segment 2-3 ducts, you can very well clear those areas. And since there is no malignancy or no tumor, there is no question of any margin status, etc.
No, the question is
occasionally I may have to do some anastomosis to that particular area of bile duct, because I was worried about some leak or something later on. I had leak 1 or 2 cases.
Okay. Now, the thing is, the aim is to clear the stones as well as if there is a stricture that also has to be resected, because there is a malignant potential.
I have seen 2 cases of malignancy as well.
Yeah.
So margin status is important when you clinically and intraoperatively suspect malignant stricture, or sometimes it may be a histologic surprise after resection.
Okay. Ubal, the surgeons have. Suppose
if I can, I think Gautam has not spoken. I have not spoken.
Yeah, both of you, please. Sorry, sir. Okay.
Sir, just a query. Like, can we see the first CT scan, sir?
Of the first image.
The first image of the thing.
That's the first image.
Yes, sir. See, sir, I don't know whether it's because of the reconstruct or not. There is irregularity involving the right side disease, right system also. Like we can see the right posterior, there is some amount of irregularity that is noted. Though it is not having stones, it might have strictures, and the disease process is bilobar, as Dr. Ilango had mentioned. To identify whether it's just an unilobar or bilobar, I don't think we should just go by the stones, but also look for occult strictures which are not symptomatic at present. So that was one thing I thought we should make a note of.
But in that case, you will prefer to go for a cholangiogram, MRCP.
Exactly, sir. So we'll have to better define the bile duct anatomy before planning for just an left. If the right side is normal, as Dr. Prathapan voiced, we would have probably chosen left hepatectomy. But since there's a doubt of right duct involvement also, it is better to clarify the status of this thing. And with respect to the CBD, this thing, I'm still not able to explain the reason why CBD should be dilated.
Okay. Sometimes hepatolithiasis is also associated with stones in the extrahepatic biliary system also. That's also there.
Okay. Then anyway, MRCP will tell us that whether there are stones there too.
Okay. Patta, sir?
Shankar, if you look at the picture, the left lobe has got a sizable volume. There's no any shrinkage. It doesn't look like there's recurrent infection in that left system. I would still give a try to one. Technically, that looks a single stricture. Quite often, you have multiple strictures where endotherapy may be difficult. Hepatectomy will be the last resort, but still, such a huge duct and very close to the hilum, I would still attempt. With Ubal around, I would attempt to dilate that stricture and take the stones out.
Okay. That brings Ubal to the picture. Would you like to try to remove the stones?
As giving opinion last is better compared to giving in the initial period. So, as Prathapan said, we also have a similar experience, almost around 60 to 100 patients in the last 20 years, because we see most Bangladeshi and Northeast patients this kind of picture. This is what probably Rajita reported as it is a classical oriental cholangiohepatitis. I'm sure that report must be oriental cholangiohepatitis. As Gautam said, it is a bilobar disease, but the predominantly there's a left lobe is involved. The stricture is very classical of left hepatic duct origin, which is angulated. It is again very classical of oriental cholangiohepatitis. The bile duct invariably have stones. The bile duct will be dilated. So these are all classical findings fit with recurrent pyogenic cholangitis or otherwise oriental cholangiohepatitis. So what I do, so that may not be the conventional techniques, and usually we'll explain to the patient, discuss with the surgeons. So these stones cannot be removed in one sittings, can be removed 2-3 sittings. What I would do is, these strictures can be easily dilatable, the stones easily could be removed. These are all pigment stones you can remove easily. It's not very difficult stones to remove it. And maybe you require 2-3 sittings, I do it every 6 months, only a time.
Okay.
And in between, I do cyclical antibiotics and deworming every 6 months. So that is the protocol of what we follow in a recurrent pyogenic cholangitis, where there is no atrophy or no severe cholangitis. Invariably, these patients will end up in cirrhosis in some point of their lifetime. So basically, our aim is, whatever the thing we are doing it, will prolong the lifestyle, prevent the cholangitis. So basic idea is to give an endotherapy, multiple sittings for a period of 1 year, discuss with the surgeon. As Prathapan said, maybe a left lateral segmentectomy in some point of their lifestyle, and finally they'll land up with a liver transplant. That is the extreme cases. So this is how we approach these patients.
Okay. So
this patient has not had cholangitis, no? Any cholangitis in this patient?
no,
Usually they'll have a very low grade cholangitis. They will not present with a classical cholangitis. They'll have a recurrent pain, fever, and that is very mild grade. Not a classical cholangitis where we require immediate attention.
Is it a variant of Carolese, where you have dilated system, hepatolithiasis, and then they develop a stricture due to the stone? So I was just thinking, because there's a dilatation of the CBD as well. What makes you say that it is RPC? Is it just because by experience that we've seen so many cases, or any other differentials that you would like to give?
The Carolese, the thing is, the bilobar, usually the dilatation is equal distribution, not predominantly left lobe. Whenever there is a left lobe predominant dilatation and the stricture where Ruchita demonstrated, that is a classical of RPC.
Well, there's a question from the audience. Why multiple sittings? Why not a single sitting?
The endoscopist will be tired because there are so many stones, so you cannot remove it in single sittings.
What about spyglass? Use of spyglass? Spyglass with lithotripsy? That
is an option, madam, because the problem is it is invariably into the second order of bile ducts. So going into the bile duct.
This particular one looks in the first order, no? Doesn't seem to be well in.
No, well, I just want to ask, you said you will do multiple sessions of endotherapy, and you also said that these patients will finally land up with complications. Basically, this is because of the fact that you are not able to clear the disease completely. So, why can't surgery be an option where left hepatectomy or a left sectorectomy will completely clear the stone load? And I'm talking about a unilobar disease. I'm not talking about a bilobar disease.
Invariably, RPC is a bilobar disease. What we see is a unilobar at this moment. But as Gautam said, there will be a bilobar, there is a pathology. Invariably, they'll have both sides. Maybe they'll go on for years, but invariably, they'll have a bilobar disease.
Okay. Now, one more question to
see, I mean, the endoscopist should also have get some hands-on experience in treating these stones. No, if you straight away like Prathapan go and operate, when will they? Because okay, now you are transecting the left lobe and taking it off. A year or two later, they'll develop stones in the right lobe. You remove the right lobe also. Then that the endoscopists have to come in there. They should have some experience of using the instrument deep inside the liver.
Can I tell something? Dr. Upal, you do repeated endoscopy, endotherapy, etc. Usually, after biliary intervention, the gallbladder has problems. Because most of these cases, gallbladder is not diseased. Usually, we see no stones in gallbladder. Gallbladder is somewhat healthy. Unless the endoscopist intervene by sphincterotomy or something like that, the gallbladder seems to be normally functioning. So if you do repeated biliary interventions, is there a risk of cholecystitis or some problem with gallbladder? As surgeon has to do a cholecystectomy if you are contemplating only endoscopic therapy.
I don't think we've seen anything like that. Well,
Cholecystitis, I don't think it is not a complication of any endoscopic intervention as such. Because what we do is we clear the duct and we'll put a stent, and subsequently in the next sitting I'll remove the stent. We'll keep the patient stent free for quite some time, and we'll reassess. So that's all. But invariably, I don't think cholecystitis. Cholecystitis is a problem of putting a covered metal stent, not with the benign endotherapy treatment. I don't think there is a complication of ERC.
How often have you seen, Prathapan, of endo intervention and gallbladder getting inflamed?
No, sir. I'm asking a doubt because after a CPT stone in cases, you do endotherapy and you will advise the patient, even if there is no stone in the gallbladder, surgeons are advised to do cholecystectomy.
That is in
So
a classical. That is in a classical
gallstone disease.
That's a gallstone disease. Okay. Ubal, just I want to ask you. You said you will do clearance of the stones in 3 or 4 sessions. What kind of instrumentation you use? Do you use a basket or a balloon, or will you use a laser lithotripsy?
We use everything, because most of them we initially try with a balloon, basket, and spyglass and laser lithotripsy.
Okay. And before I go to the next point,
what is Ilango up to?
Sir?
Ilango is for left hepatectomy.
Oh, yeah.
Sir, you're reading my mind. That is pretty dangerous.
Ilango,
So, left dominant disease with a stricture.
Yes.
I mean, it's difficult to interpret. I agree that there is a disease in the right side also. You might
we can't hear you, Ilango.
Sir, am I not clear?
Yeah, now clear. Now clear.
So this is even though there is bilateral IHBRD, the left one is dominant, and the presence of stricture or atrophy, either of those things will require a resective treatment on that lobe. And still, what we did in Bangalore for the last case was we did intraoperative cholangioscopy and then checked whether we have missed any other duct.
Okay.
And then again we warned the patient that they will need further therapies with follow-up. That is my take. I mean, it has a stricture in addition to the stone. So even if there is stone, if it is focal, the appropriate treatment will be a hepatectomy. That's a one-time treatment. At least it will control a majority of that time. And here we have an additional stricture. I would definitely vouch for a left lateral segmentectomy at this point of time.
Okay.
That's because of the risk for malignancy, is it? That's why you want to do it? Why can't we do a hepatico-HJ and then...
That is one point.
Stricture, yeah. And here the
that stricture is in the umbilical, is close to the umbilical fissure, ma'am. It's very difficult to get an anastomosis properly done.
Actually, once upon a time, I remember when the Nolan Institute, when liver resections are just coming into vogue, we had to open the common hepatic duct and try to take out as many stones as possible and do an access loop. Because hepatolithiasis is a classic indication for an access loop hepaticogenesis.
Okay.
Now, another point here is, if you see, bile duct seems to be dilated. A number of times you don't know why bile duct is dilated, but then it is dilated. And when you do an endotherapy, you also have an access there to the lower end, and you see whether any stones in the bile duct or some narrowing of the lower bile duct. I mean, that also will be addressed, my opinion.
Ubal, just one more point. Since we have seen a roundworm in the intestine, suppose you are doing an endoscopy. For some reason, you are able to see a roundworm protruding through the ampulla. What will you do?
Pull it out.
Obviously, you would have had experience of doing it.
I will remove it.
You will remove it. Okay. With a snare or?
With a snare. With a snare or a tooth.
Suppose when you snare it, half of the worm gets divided.
It never happened in my...
No, I'm just... Okay.
I just want to know, in RPC, why do you get a dilated CBD?
Invariably, they'll have some kind of CBD sludge or stone, madam, in the lower end.
It's not invariably. Just tell me the percentage, no? What proportion of patients with RPC will have a dilated CBD? See, I think if you have done an MRCP, it's nice to if you have an MRCP picture. I'm still confused whether we're dealing with a variant of, I don't know on what basis, just because from Northeast and by experience you're talking. But supposing it is not from northeast and from some other place, how often do you get a dilated CBD in a patient with RPC, and what's the mechanism?
But there's an interesting thing to be looked into, looks like.
So we'll go to the next. So this patient, obviously he was doing some shopping and he finally landed in our hospital, and that's the patient gets admitted in gastroenterology, and they wanted an MRCP for all the right reasons, and that's the image for you. The MRCP. Gautam, you only wanted MRCP. You can read this MRCP for you.
Yes, sir. Again, T2 weighted reconstructed. We can see the left hepatic duct, which is quite dilated and having filling voids. The right anterior and posterior, it's too small, sir, but I think they look okay. I'm not very sure. But
no,
the
stone in the junction.
Yeah, the filling void is in the junction, and below that we have the dilated CHT and CBD2.
Yeah,
there's some stones lower down.
Yeah, most likely, sir. Most likely there is a filling void there also. I'm not sure because the right anterior is like coursing over the apparent filling void towards the left duct. Yeah, there is a small window. Whether it's there's a stone sitting right at the bifurcation of right anterior and posterior, which is a possibility. Okay. Extending from the hilum.
So basically, this MRCP shows the right system seems to be okay only, and definitely the left duct is massively dilated with stones. CBD is dilated, and probably there is we do not know whether there is some sludge there or anything like that. And at this area, there could be some filling defects in the close to the confluence. So that's the MRCP. So now, Ubal, you want to still do the endotherapy for this patient?
Yes.
Yes. Okay.
All the more endotherapy.
Okay.
Suppose if do just the left lobe removal and leave the hilar stone behind, then he had it.
Now, the question is, I just want to take the opinion of, is it because you have the skill to do it, or is it across the board, every person doing ERCP can clear this disease? That's what I want to know. So you said you have experience of more than 60 cases. Probably you would have devised your own techniques of clearing this. But a regular person who is doing routine ERCP, will he be able to clear this? That's the question.
Very difficult because, as I said, because we have to explain to the patient that you require multiple sittings, and that's the reason. Not only the skill set, you need a lot of patience. Because you have to remove the hilar stricture, you have to go the hilum and dilate the stricture, then only you have to bring out the stones. So, not only technically, you need a lot of patience to do these procedures. Okay. And that is again important. And patient acceptance and willingness for multiple sittings. So, working in a corporate, that is a better advantage. You can get an opinion from surgeon because they'll ask the surgical effects and the cost and other things. Then compare both, and they'll prefer endoscopic modality. Most of the surgeons, I feel they prefer an endoscopic treatment over a straight away for a surgery. In these kind of benign conditions requiring benign diseases, I feel most of them, they refer for endotherapy. Even though it is a multiple sitting, they prefer endotherapy.
Okay. So the house is divided on, there is a...
Now, in retrospect, of course, I'm not against surgery. Surgery will be the eventual treatment. How do you suppose, based on this particular, the previous CT scan, and you've gone ahead, Pradhaban, and just removed that the left segments, and how do you locate? Do you identify that stone in the hilum? Can you do that?
No. During exploration, you can always palpate the hilum, no? If there are stones, you can take decisions based on your intro experiences. Yeah, usually we will do if you have suspicion of dilated CBD, if there is a suspicion of lower part sludge and all, you have to invariably explore the CBD. Yeah. So if there are multiple stones in the CBD, you have to clear the stones. but it is very difficult to access the stones which is beyond the stricture in the left hepatic duct. In such situation, I have failed many times to remove through the choledochotomy incision. I had to make an intrahepatic hepatomy or something like that and open the bile duct in the liver parenchyma itself and clear all the ducts. And after some time, I found it's very difficult to have a hepatotomy and doing this thing and removing atrophic segments or some parenchyma beyond that. You can make an anastomosis and clear the duct. One endoscopic intervention, he developed that. We did an incision and drainage of the abscess, and the patient had a fistula through which all the stones were draining out.
Okay.
So sort of situation sometimes happens, and they may develop an abscess which may produce spontaneous rupture and produce some issues. Occasionally, we get cases like that. So this patient needs CBD exploration as well. If there is dilated CBD, we can't leave the bile duct as is.
In 1991, there was a workshop in Apollo, Hyderabad. I was an MCH student that time. And there's one Japanese surgeon who does percutaneously through a scope, fine scope, cholangoscope. He will access this particular area, and with the cholangoscope, he is to deal removing the stones and dilating the strictures.
Okay.
I mean, you can combine both, say from above and below. I mean, instead of right away going for a resection for a disease which can be bilobar.
So basically, you'll have to tailor the treatment according to the expertise available, the experience, as well as depending upon the morphology there and the stone load and the stone distribution. So all the factors has to be taken into consideration, and sometimes you have to have a team approach. Part of the treatment is done by the endoscopist, and then you can always go for a surgery also. So this patient that's what I was asking, what is the role of ERCP, and this patient obviously underwent an ERCP, and they cleared all the sludge and thing within the bile duct, but they could not clear the stone load in the left hepatic duct because of for some technical reasons. So as Ubal told, you should have patience, perseverance, and interest, passion if you are going to do an endotherapy, because it's going to be a very challenging thing. It's not going to be easy trying to clear because the stones will not be only in the major ducts, even the smaller ducts will have a lot of calculi. So that's why the Chinese and East Asian people have published literature which says that hepatectomy is the treatment of choice in unilobar disease. Anyhow, but always there is a scope for endoscopic treatment, provided they are able to clear it completely. Because this is always leaving behind a stricture has a pre-malignant potential. All these things are there. So this patient underwent an ERCP and clearance of the stones only in the bile duct. Left hepatic duct they could not clear. So finally it was given to the surgeon. And
you have the ERCP picture?
Sorry, sir, I don't have the ERCP pictures, sir. So that's the left hepatectomy done, and you can see how the stones are packed here. And if you cut open the liver, you can see the dilated duct, and you can see all the small radicals are filled completely with small stones. It is very difficult to remove these stones because you can only clear the bigger stones. These small stones will once again manifest itself, and because we do not know how much of this stricture is contributing to the cholestasis and stone formation, you can see all the small ducts are filled with stones. So that's the reason why the Chinese are propagating the concept of in a unilateral disease. If you can clear it, a left hepatectomy or a left lateral sectorectomy will be the treatment of choice. If an endoscopist have to clear it, it's a very tedious job, but not impossible, as Ubal has told and has shown his experience also. And these are all the stones that hepatolithiasis, and so many stones.
What is the histopathology? Does it the stricture area?
Histopathology was, obviously
And
there is
what
no,
about the
no
stone
evidence.
in the hilum?
No, that was removed during ERCP.
Okay.
That was during the removed. They were able to clear the bile duct, but the left hepatic duct was is. Ubal, is it you have a problem in clearing the left hepatic duct because the orientation changes, the angulation. Because whenever you are manipulating the CBD, you are dealing with a straight tube, whereas here you are going to deal with a horizontal tube there, left hepatic duct.
Yeah, you require a lot of, not only you, your assistant also very important, because
Okay.
manipulating the guide wire across the left duct will be difficult. Sometimes change of patient position will help, and that orientation. Here we are liberal to use contrast, because we know that it's a benign disease and we can demarcate the anatomy clearly. And with the available, because we have a lot of accessories now, angle guide wire and guide wires that can be rotatable.
Okay.
So those things will make things easier for cannulating to the right duct, even beyond the stricture, dilating the stricture.
So your armamentarium should be fully equipped. It cannot be done by a regular person. That's correct.
No, actually, Ubal's armamentarium is very strong. When I was there.
Okay. Now
That is the biggest armamentarium we had.
Okay. Few words
Sir,
about.
can I just add a comment, sir?
Yes, Gautam.
Sir, regarding that cut section of the liver, it was rather surprising to find the liver actually very soft. Generally, what happens, they have recurrent episodes of cholangitis, they become little hard, and even the cut section bile ducts will start throwing pus.
Okay.
That is what is the usual trend. But I think this patient had relatively come to us little early without too much of cholangitis episode.
Okay. Now, Madam Jayanti was telling about whether it could be a Caroli's disease or a variant of choledochal cyst with a stone disease there. That is definitely a possibility, not in this particular patient. The Western literature is, their experience of hepatolithiasis is all about stones which are formed in the intrahepatic choledochal cyst variants only, because they don't see the classical recurrent pyogenic cholangitis in the West. Of course, now with the emigration of people, they are seeing cases, but the hepatolithiasis of the seen in the Western countries is basically occurs in the background of primary sclerosing cholangitis or choledochal cyst, but not the classical hepatolithiasis with the pigment stones, calcium bilirubinate stones.
I think for the PGs, you have to give a clear message. What will be the differentials for a patient with this presentation? What are the 2 or 3 differentials you should give in this patient with that clinical presentation?
Madam, the typical left lobe predominant disease is one characteristic feature of hepatolithiasis due to recurrent pyogenic cholangitis. The other, and especially if the patient is coming from the endemic area or where the disease is more common, RPC will be the first diagnosis. Suppose you have, if you want to give a differential diagnosis, other things can be a variant of choledochal cyst like Caroli's disease, which is having a cystolithiasis, where we don't use the word hepatolithiasis, we use the word cystolithiasis. Primary sclerosing cholangitis can also produce intrahepatic strictures and stones. So these are all the 3 or 4 differential diagnoses you can give. And basically the whether it's from east or west will what determine the etiological factor. And I think India with the helminthic infections being rampant, I think we have to go with something like a RPC only. We cannot think of.
Is this being described in roundworm infestation from North Srinagar, Kuru's studies? I don't think they've discussed RPCs and hepatolithiasis in roundworm. If I'm,
I don't think so, madam. I don't think they're linked actually.
Yeah, roundworm they're not linked as hepatolithiasis. It is something unique to some population, that's all. And why it occurs in that particular population, I do not know.
And actually, in China, Taiwan, etc., where possibly roundworms are not very common, also even there, that's the area where these things came from actually. RPC. Now, the other thing, second thing is, again, it goes to prove that a single investigation like a CT will not give a complete information. Actually, here you see, we had all the 3. We had CT, had MRCP and you had ERCP also. I think more than one investigation will be necessary before making a treatment protocol.
Most of these stones in RPCs are brown stones, no? These are all black, typical black amorphous stones that we see in gallstones. So that is also surprising. RPCs are all soft, pultaceous brown stones.
What is this picture for, Chandra?
So, I just want to tell about few words about hepatolithiasis. This is the East Asian countries where you have high incidence. And the etiological factors, we do not know exactly what is the cause. There is a genetic predisposition, whether it has to do with any food. Because the East Asian food is more rich in carbohydrates and low in fat and proteins. Environmental factors, infections, ailments, all these things have been postulated, but no, we do not know definitely what is the exact. And these are all the biliary ailments like Clonorchis sinensis or Opisthorchis viverni. Ascaris lumbricoides can produce definitely biliary ascariasis and some kind of stone disease, but may not be a typical hepatolithiasis. Of course, Pratapan was telling about high incidence of ailments. As far as the goals of treatment is concerned, these are all the goals which are clearly mentioned. Number one, you have to resolve the ongoing infection. Number two, you have to prevent recurrent cholangitis. That's very important. Thereby, you will prevent recurrent hepatic fibrosis and going for cirrhosis. And you have to, one of the goals is you have to decrease the need for repeated instrumentation. That's an important goal that has been described in the treatment of these patients. And you have to, by all these methods, you will prevent the progression to cholangiocarcinoma. Now, that's the Dong's classification. I'm not going to, it's all there in the book and you can read it. And basically, hepatectomy is indicated for if you have a unilobar hepatolithiasis or when there is a bilobar disease with atrophy, fibrosis, and abscesses in predominantly one lobe. So these are all the, and when you have an intrahepatic strictures and suspicion of malignancy, all these things are very definite indications for doing a hepatectomy. So various treatment options we have already discussed. It could be a hepatectomy or it could be a hepatectomy with a bilioenteric anastomosis with an access loop. Of course, all other methods like ERCP, stone extraction, percutaneous methods, even doing a CBD exploration and using a ureteroscope and laser lithotripsy, that's what they practice in CMC Vellore. So basically, I just want to say that you have to tailor the treatment according to the experience, expertise, morphology of the ductal system, presence of strictures, and lobar involvement, as well as stone load and stone disease. So
we have some opinion from the floor. We have Dr. Rajaratnam, Padmanabhan Rajaratnam. We have Surendran. Any comments, please? Dr. Surendran?
Yes, so still there is a chance of recurrence on the right side, right system. And still there's still a chance of microliths in the right system. So you're not anyway going to prevent the cholangiocarcinoma. So what do you do if there is a recurrence on the right system?
What the Chinese have shown is even they have gone for a resection of bilobar involvement. So basically, that's what I told you. Right now, what is the morphology? What is the disease? You can treat it. You cannot prevent the future, but if the patient develops that, you will have to take call based on the what is the morphology of the disease. Say, for example, you have done a left lateral sectorectomy, and now the patient develops stones in the right posterior ductal system. Then you can go for a right posterior sectorectomy. In fact, the Chinese have gone for bilobar resections in staged procedure and leaving behind central portion of the liver. So you have to offer treatment for the pathology that you have to deal with at the moment. But definitely, because we do not know what is the etiology of this disease, there is going to be an ongoing problem. And finally, that's what Uval said. Most of these patients might finally end up in a cirrhosis with liver transplantation. That has been well proved. So how far you can keep on pushing the biliary cirrhosis and transplantation is the question.
Any other comment here, Dr. Viplov? Any other comment?
Dr. Sankar, I would like to know
Yes, sir.
if this patient has possibly very early right ductal system disease, which may manifest later. try to prolong the development of cirrhosis and other complications by doing maybe something like a segment 2, segment 3 exposure, remove it, and do a hepaticojejunostomy so
Yes.
that you prevent cholangitis.
Yes, definitely. I mean,
In parenchyma.
doing a hepaticojejunostomy with the access loop is a well recommended procedure, sir, because basically you'll have to access these loops periodically. So that's what, if suppose you have a bilobar disease and predominantly the left lobe is involved and the right lobe shows minimal stones, what you can do is you can do a left hepatectomy and a hepaticojejunostomy with an access loop, either into the duodenum or into the stomach or into the, you can bring it to the skin, depending upon the expertise, whether you can have an endoscopic access or a radiological access. And the right system has to be periodically accessed and you have to clear it. So definitely, if you have a bilobar disease, that is definitely an option.
No, I'm asking here. You do only a segment 3 exposure. And
Here
do a
is,
clearance and hepaticojejunostomy at segment 3. Segment 3 hepaticojejunostomy, for example.
no, no, sir. There is a stricture sitting at the left hepatic duct, so that has to be addressed.
No, that's what. Whatever is to the left of the stricture will drain into this system. Segment 3, like we used to do segment 3 drainage.
Yeah, but here this patient, the right system seems to be normal. So with the presence of a normal system, there is no need to do a hepaticojejunostomy at that point of time. That's what my opinion. But
I'm not talking hilar hepaticojejunostomy. I'm talking about segment 3 hepaticojejunostomy. You approach the left duct, drain everything, and put a loop there, maybe with an access, so that your left system is taken care of, parenchyma is preserved, and you're preventing this cholangitis.
Sir,
yeah, Ilango.
Sir, that left duct is too big, sir. It will not drain very well. And in the presence of a stricture, a lot of these guys who have done good work on this hepatolithiasis, once they form a stricture, it's very difficult to drain properly. It's a much simpler procedure to do a hepatectomy and do away with the lobe.
I'm not asking. See, since we need to have this knowledge disseminated to the students, they should know why a simple procedure like a segment 3 would not work in a case like this.
Sir, you are telling segment 3 hepaticocholangiojejunectomy, we do it for a palliation for a hilar cholangiocarcinoma. You are telling
like that.
No, I think Bhaskar is talking about a theoretical possibility.
I mean, actually, segment 3 bypass is not a good option for hepatolithiasis. That's my opinion.
Shankar, is there in literature support to say why left duct stones and left stricture predominates? Why not right? Any particular reason? Any angulation or anatomy or anything like that?
So just common sense tells me that it is more horizontal. I don't know. I really don't know why this left duct is most of the times involved, except it being horizontal, and I cannot explain how. And I'm not able to find out the answer in the literature also. If any of you can tell, maybe Ilango can tell.
Yeah, Prathapan, you're saying something?
Sir, that junction between segment 4 ducts and segment 2-3 ducts, there is the site of stricture most of the time we see. I think there is some anatomical points which favor that area, or that may be due to more horizontal lie of segment 2-3 ducts. I have seen right system alone disease without left system disease as well.
Okay.
But if there is right system affection, the atrophy is very maximum compared to the left system, because the right lobe atrophies and the left lobe hypertrophies. There may be some other vascular or some congenital problem as well. I have seen one patient with predominantly exclusively right system disease.
Yeah. Shankar, anything further?
Yes, sir. I've completed, sir. Your closing comments only.
Any other comments before we close? Anybody from the audience? If you open the chat box, Neelendra Yashasvi wrote something. Shankar, just have a look.
He's my postgraduate only. Why he's writing, he can call me and ask.
He's scared of.
So he wanted to show that he is listening to your lecture. That may be the reason.
He's documenting his presence. Okay.
So you don't bother about the comment. Okay, fine.
Now, what's the comment, sir? I'll just answer it.
Segment 3 drainage might drain main duct, but not the territory radicals. If we see the post-op pictures, sir, there are small stones in the small ducts which can't be drained or accessed with access tubes. So this is to Bhaskar.
Yeah, it is not necessary to remove every stone one sees. As long the stones are secondary to your stricture. So that is the primary thing. It is not that stones cause stricture. As long as there is adequate drainage, cholangitis is not going to be there. And this patient as such does not have significant cholangitis. I was just trying to see if he can retain parenchyma for longer time, his chance of developing the biliary cirrhosis would probably be much less for a period of time. Because he is likely to develop disease on the right side also, then it's going to be a problem.
Sir, I want to just clarify one thing here, sir. In hepatolithiasis, stone formation is the first event and stricture occurs later. It's not that stricture forms and stones forms later. It's always opposite. There is a primary stone formation within the bile ducts, and because of the recurrent infection and stones, the stricture forms. That's usually the chronology of events.
Yeah, that's true. What Sankar says too. The stricture is actually secondary. It's not the primary event. So that's the reason I think invariably the stricture usually you can dilate easily. It's not the primary fibrotic stricture.
Well, see, whether strictures cause the stones cause stricture. Because I don't know if the stones have to cause stricture, they have to cause everywhere, including the common bile duct. Strictures cause stones undoubtedly because of the mechanical thing, but how will stones cause stricture? I think there is some other pathology, which is responsible for the stricture formation, not just stones. Stones have to grow for some time, but they have to be located there. They have to erode and do something.
Stones cause recurrent inflammation and strictures.
Actually, that's of the pathology. Actually, it is a recurrent. If you see in a lot of RPC, the strictures may not be there. Predominantly, there may be only stones.
Yeah, I agree, sir. Stones are found without strictures also.
So, not necessarily the stricture may be a classical finding in the late stage of disease. As what Sankar is saying, this is a progressive disease. We are doing on a particular point of time where there's a lateral segmentectomy. It's feasible in this patient. The same patient, we continue to have progressive disease, he may require a subsequent endoscopy treatment or hepatic angioedema with excess loop. We have seen entire spectrum of disease, including a liver transplant, finally land up with. So this is a progressive disease. Patient has to be treated at what stage they are presented to you. It is that's the reason I said endotherapy is the initial mode of treatment, because we don't know how they progress. So you give an option of endotherapy at the first sitting, maybe 2-3 sittings. There is no harm in doing that. The surgeons can take over the place in the subsequent visits. Even my first ERCP, I can definitely say that I can remove the entire stones, or straight away they can go for surgery. Okay. That is also possible by an endoscopist to give the feedback to the surgeon. I think the endotherapy will also give a clear anatomical picture, because whatever MRCP CT, ERCP is a gold standard for any biliary imaging.
Okay.
But in a condition like benign disease like this, if you put a contrast, inflate the balloon in the hilum and put a contrast bilaterally, you fill it up. You know exactly what kind of disease, where exactly the stricture, everything we can clearly say. So I think the endotherapy should come as a first. This kind of benign disease, not a severe cholangitis, rather than straight away go for surgery, endotherapy, getting input from the endoscopist is mandatory for a surgeon to proceed.
Okay.
Any follow-up surveillance required in these patients?
Definitely, madam. This is a progressive disease. This patient should be.
What's the protocol for surveillance?
I think based on the symptoms only, madam. There is nothing like maybe you can do an LFT repeated every 3 months or 6 months.
Yeah, every 6 months. It depends on where they're coming from, madam. Every 6 months, 1 year, you can call up for imaging or ultrasound, basic ultrasound.
Tumor marker?
Tumor marker, you can do it, madam.
Is there any protocol guidelines for managed following? That's what I'm asking.
Sorry, madam, I am not aware of any guidelines. And Ubal, I want to ask one more question. Will this ursodeoxycholic acid will be of any help in these patients to prevent future stone?
No help in pigment stone.
Okay, madam. Okay.
No, I have a clarification on that. because most of these patients who underwent surgery, when they are on ursodeoxycholic acid, they get less symptoms compared to those who are not on ursodeoxycholic acid. So
Okay.
they may get recurrent episodes, and one course of ciprofloxacin plus continued ursodeoxycholic acid gives a long-term symptom-free interval in this patient. That is what I find on
Observation.
following.
Maybe, I mean, UDCA may be acting as a cholinergic agent, but not for purpose of dissolution of stone.
It won't prevent stones, but it will prevent presence of repeated infections.
Cholinergic act, yes.
As Prathapan said, I also use ursodeoxycholic acid and maybe a cyclical antibiotic and deworming.
See, Shankar, Dr.
Yes, sir.
Padmanabhan Salem Rajaratnam is asking about, he wants a word about laser. Ubal, maybe you can comment the role of laser in your armamentarium, how often you used in treating these stones.
Laser only after the spyglass, because before spyglass, I think it is very difficult to target the stones. Now the availability of cholangioscope, we used both laser as well as electrohydraulic lithotripsy. But this kind of intrahepatic stones, again, I said that it's difficult to access because the laser, you have the fiber that is very stiff, and you should not injure the parenchyma also. You have to target the stones. So very difficult to this kind of intrahepatic stones. In a CBD stones, it is easier done. For intrahepatic stones, I think it is difficult.
I think for the laser, the largest experience is from CMC Vellore. I think Ilango is going to tell about that. Because they use a ureteroscope. They do a choledochotomy and they pass the ureteroscope and literally break all the stones with laser and remove it.
Sir, are you all kidding me? I have very little experience in RPC, unlike you. I have seen hardly 2 or 3 cases.
Okay.
But I had a doubt. I wanted to clarify that with Ubal sir. Ubal sir, for left hepatic duct access in segment 2-3 access, how easy is it for you to reach through the ERCP scope? Can you give us some technical details? Hello? Ubal sir?
That's what I said, no, with the angulated wire and with the different accessories.
Okay.
Either you can use a cannula or a sphincterotome. You have to bend the sphincterotome in the middle of the CBD, and you can access because of your technician and your accessory is very important. And
Okay.
sometimes you can use your balloon and occlude the right duct and go into the left duct. That is again a possibility. So there are various methods. So sometimes change of patient position also you can access it to the right side system.
So for postgraduates, we can say that as long as the stones are in the common bile duct, we are going to do well with ERCP. But once it crosses the umbilical fissure on the left duct, then I think ERCP is technically difficult. It has to be surgical. Can we make a general statement like that?
Yeah, that we can make a general statement.
Yeah. Okay, sir.
And before we close, I request Ubal and Prathapan to, because both of you say that you have more than 60 cases, so you have to publish your data, because that will be a very useful literature evidence from us. Ubal?
Told one of him PG long back, I think in 2008 or 9, to collect all these. He collected and ran away.
He must have passed out.
He'll be in the northeastern part of India now, right now.
Ubal, there is a saying nowadays everywhere, in God we trust, others will have to bring data.
Okay.
I think it's a wonderful session. Actually, Dr. C.R. Ballal was talking to me, a senior professor, on the phone, and said, yesterday's Meckel's diverticulum, I was so impressed with the discussion. You know, it's so pointed and so useful. I think this discussion is no less, and we understand that no single specialist can deal with it. I think we should have a combination of specialists and do a sort of via media decision making. And I think everybody has got a role to play, and every imaging also has got a role to play. And I think there are much more to be learned, and so many. I have written a lot of questions to be looked into. Thank you all so much, and thanks, madam, for being there. And I think we shall again meet on Monday in this forum, because tomorrow we have the TNISG.
Yes, sir.
Followed by testicular tumors by Dr. Shivakumar from Madras Medical College. And then
Sir, 4 o'clock, that HCC meeting.
Sorry. It starts at 4 o'clock. The day starts at 4 o'clock with Ilango et al.
Okay, sir.
HCC
Sure.
part 2.
We'll all be there. Thank you, sir.
Thanks, sir.
Thank you.
Thank you all so much.
Good night. Good night, all of you. Good night.
Good night.
Right.